Alright, let's take a break from the seriousness of heart failure for a hot minute and hit the country music festival. It's about time we caught some tunes. In this sketch, we'll talk about what happens when the lining of the heart, known as the pericardium, gets inflamed. In part 2 of this series, we'll talk about some of the other diseases that can affect the pericardium, and finish up with inflammation of the heart tissue itself, known as myocarditis. Okay, that's enough. Thank you. But first, as always, let's begin with some definitions. See that guitar case? That's a recurring sketchy symbol for the pericardium, a fibroelastic sac surrounding the heart. Similar to the pleura surrounding the lungs, the pericardium is composed of a parietal and visceral layer. The space between these two layers, known as the pericardial space, normally contains a very small amount of fluid. Pericardial disease can present clinically in several ways. The most common of them all is acute pericarditis, which refers to the inflammation of the pericardial sac. At Sketchy, if a guitar case represents the pericardium, then pericarditis must be a flaming guitar case. A pericardial effusion, which doesn't always occur in conjunction with acute pericarditis, is present when fluid accumulating within the pericardial space exceeds the small amount that's normally present. If pericardial fluid builds up, eventually the pressure within the pericardial space begins to increase. Cardiac tamponade occurs when the intrapericardial pressure becomes so high that cardiac function is impaired. That said, fluid accumulation isn't the only process that can compress the heart. A number of diseases can result in scarring and subsequent loss of elasticity of the pericardial sac, a condition known as constrictive pericarditis. This sketch will be dedicated to acute pericarditis. To learn more about pericardial effusion, cardiac tamponade, and constrictive pericarditis, check out part 2 of this series. For now, let's dive into the clinical presentation of acute pericarditis. The most common symptom of acute pericarditis is sharp pleuritic chest pain, represented by our recurring sketchy symbol, the shark tooth necklace. The pain is classically improved by sitting up and leaning forward. Yep, just like this guitarist. Look how happy he is. Patients with an infectious etiology may present with signs and symptoms of systemic infection, like a fever, represented by our recurring sketchy symbol, the flame headband. Viral etiologies in particular may be preceded by a flu-like illness, represented by those used tissues lying around on stage. If the first few minutes of your history taking have you concerned for pericardial disease, your next few questions should be directed towards figuring out the underlying etiology. Let's get the most common cause of acute pericarditis out of the way first. And man, is it a doozy. Just kidding. In the vast majority of cases, the etiology of acute pericarditis can't be determined. In these idiopathic cases, the cause is often presumed to be viral. Of the cases where an etiology of acute pericarditis is identified, the most common cause is malignancy, represented by our recurring sketchy symbol, the cancer crab on that lady's jacket. So, country? Anyways, metastatic lung, breast, Hodgkin lymphoma, leukemia, and renal cell carcinoma can all spread to the nearby pericardium and cause havoc. Don't forget to ask about previous MIs. Myocardial infarctions, represented by our recurring sketchy symbol, the broken string on that heart guitar, can lead to acute pericarditis in 2 different ways. When pericarditis occurs within 3 days of the MI, it's called peri-infarction pericarditis. Hence the 3 suns on that strap of that broken heart guitar. Peri-infarction pericarditis results from acute local inflammation associated with the MI. Pericarditis can also occur weeks to months after an MI, a condition known as post-myocardial infarction, or Dressler syndrome. Hence the many moons on this woman's dress. Love puns. Dressler syndrome is thought to result from an immunologic phenomena that take time to develop after an MI, which is why her dress is also adorned with these antibody designs. Très chic. Collagen vascular diseases, especially systemic lupus erythematosus, represented by a recurring sketchy symbol, the lupus wolf, can cause pericarditis. In fact, acute pericarditis can often be the first presentation of lupus. Whoa, Wolfie. This ain't Howl at the Moon. You're at the wrong bar, buddy. Mediastinal radiation therapy, represented by that radiation symbol in the lights, can also cause pericarditis. Chronic hemodialysis or end-stage renal disease prior to dialysis initiation can cause uremia, which can cause uremic pericarditis. This is often seen when the BUN is super high, like greater than 60. Hence our recurring sketchy symbol, the BUN bun bag. An important part of this complete country festival. Breakfast. Whatever. You know. Other less common causes of acute pericarditis include tuberculosis, Lyme disease, HIV, and drug effects. As you can tell, a bunch of diseases can mess with the pericardium. These etiologies can cause any type of pericardial disease. So, we'll be coming back to this list in part 2 of this series. Foreshadowing. For now, let's move on to the objective findings you'll see in acute pericarditis. The classic physical exam finding in acute pericarditis is a pericardial friction rub. The sound is described as a leathery, squeaking noise. Kind of like the sound those nails must have made as that woman's being dragged off the stage. Ugh, hate that noise. Pericardial friction rubs are best heard over the left sternal border with the patient sitting up and leaning forward, which is why these nail marks cover the left side of that leather jacket. While they tend to come and go, pericardial friction rubs are highly specific for acute pericarditis. Unfortunately, no other exam finding is, so the physical exam in acute pericarditis is often unhelpful. While acute pericarditis itself doesn't cause hemodynamic compromise, it can occur in conjunction with a large acute pericardial effusion that can by causing cardiac tamponade. We'll talk about pericardial effusion and cardiac tamponade in part 2. Since acute pericarditis is an inflammatory disease, laboratory signs of inflammation, such as an elevated white blood cell count, represented by a recurring sketchy symbol, the elevated white birds, ESR, represented by this elevated wind chime, complete with test tube shaped chimes and rouleau in the middle, and CRP, represented by this elevated CRP carpet, are common findings. Acute pericarditis may be associated with increases in cardiac biomarkers like troponins, represented by a recurring sketchy symbol, the T-bone steak. When this happens, patients should be considered to have combined myocarditis and pericarditis. Check out our dedicated sketch on myocarditis later on in this chapter for more details. Once you do, you'll get why we've called this bar the Flaming Heart. Unfortunately, no lab result is diagnostic of acute pericarditis. Instead, use blood tests judiciously to look for the potential etiologies we mentioned earlier. This can include anti-nuclear antibodies for lupus, BUN for uremic pericarditis, HIV, or TB studies for specific patients. Remember how we said earlier that viral infection is presumed to be the most common cause of acute pericarditis? The reason we said presumed is because viral studies should not be routinely ordered, since they won't change the management of these patients. While labs may not be helpful, other studies definitely are, especially the ECG and echocardiogram. The classic ECG changes you'll see in acute pericarditis are diffuse ST elevation, represented by all those ST street signs up there, and PR depression, represented by Perry's fallen PR manager, in all leads except the right-sided leads, AVR and V1, where reciprocal changes, that is, ST depression and PR elevation, are seen. That's why the ST street sign on the right side is falling down. Anatomically correct, son. I really can't pull that off. These ECG findings are in contrast to what you might see in a patient with a STEMI, where ST elevations would be limited to anatomic regions corresponding to the coronary distribution affected. The exception to this rule, and there's always one, is uremic pericarditis. So let's head back to the burger stand for a sec. See how that ECG grid-patterned wax paper has nothing on it? That's because the classic ECG findings of acute pericarditis are not seen in uremic pericarditis because uremia doesn't cause epicardial inflammation, which is the mechanism responsible for the ECG changes seen with other causes of acute pericarditis. Beyond the ECG, every patient with suspected acute pericarditis should receive an echocardiogram, represented by a recurring sketchy symbol, the heart-shaped megaphone, to check for pericardial effusion, a common complication. At sketchy, pericardial effusion is represented by this guitar case filled with water. Fans, am I right? Note that the absence of a pericardial effusion does not rule out acute pericarditis. Confusing double negative, I know, but don't worry. We'll go through the details of pericardial effusion in our next sketch. So, your patient's got pleuritic chest pain. What else can it possibly be besides acute pericarditis? Two of the most common causes of pleuritic chest pain include pneumonia and pneumothorax. Fortunately, they're both very easy to pick up on routine chest x-ray. The other disease that classically produces pleuritic chest pain is pulmonary embolism. To evaluate for that, order a D-dimer or CT pulmonary angiography according to the patient's Wells score. For more info on the evaluation and diagnosis of pulmonary embolism, check out our dedicated PE sketch. Let's summarize the classic presentation of acute pericarditis in a sample assessment statement. Cardi Perry is a 50-year-old woman with no significant past medical history who presents with 2 days of sharp pleuritic chest pain that improves when leaning forward. She had a cough and sore throat 2 weeks ago that she's completely recovered from. Physical exam is unremarkable. Her ECG reveals a sinus rhythm with new diffuse ST segment elevations. Given these findings, I'm concerned for acute pericarditis, most likely related to her recent viral URI. Congratulations! You've diagnosed acute pericarditis. Now what? The treatment of acute pericarditis should be targeted as much as possible to the underlying etiology. But wait, if more than 80% of cases are quote unquote idiopathic, what are we supposed to do for all these patients? For nearly all patients with acute idiopathic or viral pericarditis, a combination of NSAIDs, represented by our recurring NSAID fire extinguisher, and colchicine, represented by the famous colchicine backup singers, is the treatment plan of choice. Fortunately, most patients recover after a couple of days of treatment. If your patient with acute idiopathic pericarditis isn't improving after a week of NSAIDs, you should consider other, non viral causes of acute pericarditis. The combination of NSAIDs and colchicine is also used to treat patients with pericarditis due to Dressler syndrome. In this case, since the patient is post MI, the NSAID of choice is aspirin, represented by our recurring sketchy symbol, the ASA umpire. Not sure what you're doing at a country bar, or why you're bouncing in umpire gear. Either way, you're a mystery guy. However, if your patient has peri-infarction pericarditis, let that fire burn and don't give NSAIDs. That's because anti inflammatory medications, other than the aspirin you'd normally give for secondary prevention, given immediately after MI, can interfere with scar formation and predispose your patient to ventricular free wall rupture. If your patient has uremic pericarditis, that's one of the indications for urgent dialysis. Remember your AEIOUs for urgent dialysis: acidemia, electrolytes, intoxications, overload, and uremia. Have no clue what I'm talking about? Check out our dialysis how-to sketch for more details. At Sketchy, hemodialysis is represented by this guy simultaneously getting a nice cold drink from the dialysis fountain while pouring his nasty old red drink out the other side. Rarely, systemic glucocorticoids can be used, such as in patients with collagen vascular diseases, in which it's the primary treatment for the underlying cause, or in pregnancy, in which NSAIDs are contraindicated. However, don't use them in most cases because they're associated with recurrence of pericarditis. Finally, you should also instruct your patients to avoid strenuous activity until the symptoms have resolved, since this can cause recurrence of symptoms. Just dandy. Let's take an encore and review what we've learned in this sketch. Acute pericarditis refers to inflammation of the pericardial sac surrounding the heart. The classic presentation of acute pericarditis is pleuritic chest pain that's relieved by sitting up and leaning forward. For the vast majority of cases of acute pericarditis, no cause is ever found, and we usually assume it was caused by a viral infection. Of course, having some preceding viral URI symptoms wouldn't hurt, but not everyone's going to remember a cough or a sniffle a few weeks back. Two super interesting causes of acute pericarditis are associated with MI. Peri-infarction pericarditis occurs immediately, within 3 days of a recent MI, and is caused by spreading of local inflammation. Dressler syndrome, on the other hand, occurs many moons after an MI, and is the result of immunologic mechanisms that elicit an inflammatory response. Acute pericarditis can also be caused by cancer, collagen vascular diseases like lupus, radiation to the chest, and uremia. Lots of causes, I know, but you'll get used to them by the end of this series on pericardial disease. The classic exam finding in acute pericarditis is the pericardial friction rub, a high-pitched leathery squeaking sound best heard over the left sternal border with the patient sitting up and leaning forward. Inflammatory markers like white blood cells, ESR, and CRP will also be elevated because, well, pericarditis is an inflammatory condition. If you see elevated troponins in the setting of classic pericarditis symptoms, think myopericarditis. Other tests that'll help you nail the diagnosis of acute pericarditis include an ECG, which classically shows diffuse ST segment elevations and PR depressions, as well as an echo, which may show a small pericardial effusion. The mainstay of therapy for acute pericarditis depends on the underlying etiology, But for patients with presumed viral pericarditis, a combination of NSAIDs and colchicine works best. Alrighty, time to blow this popsicle stand. In our next sketch, we'll review the other pericardial diseases you'll need to know: pericardial effusion,